Hi, this is David Thompson, a member of the Quality and Safety Research Group. I'm a doctorally prepared nurse who's worked in quality and safety for about 10 years. I've just completed my own randomized controlled trial looking at diminishing central line associated infections. And I'm here today to talk to you about central line dressing changes. The terminology for lines included are percutaneously placed central lines, tunneled lines, peripherally inserted central catheters or PICC lines, vascular access devices. May or may not include hemodialysis catheters, dependent on what your site has decided to include. Who completes the dressing changes would be nursing personnel who have demonstrated competency for central line dressing changes, including PICC teams if you have separate PICC teams, and nurse practitioners, and any medical personnel that have demonstrated competency such as physicians and/or physician's assistants. We believe that the frequency at which the dressing is changed is based on the kind of dressing. So the CDC recommends that often one dressing for the life of the line. So after reading that and you go on further, it would say once weekly if a transparent dressing is used, such as Sorbivu or Tegaderm. You change the dressing every day if you're using gauze dressing while the patient is bleeding. Once the patient's bleeding has stopped and you switch over to transparent dressing, you can change it once a week. At time a dressing is no longer occlusive, it becomes damp or is visibly soiled, it is recommended that the dressing be changed. Equipment that you need. We've been using chlorhexidine gluconate at 2% with isopropyl alcohol at 70%, one swab, a set of sterile gloves in your size, clean gloves for removing the dressing, your transparent dressing or gauze, mask for person applying the dressing, a cone mask for the patient, skin prep, tape if gauze dressing is going to be used. Additional supplies that you may need, sterile cotton tipped applicators if you need to cleanse the insertion site of blood, a sterile cup to hold the sterile saline that you're going to be using to cleanse the insertion site, and again, the normal saline. Adhesive removal pads or alcohol wipes to get the dressing off, and a sterile 2x2 gauze if you're going to be applying a gauze dressing. In order to prepare, explain the procedure thoroughly to the patient and any family members in the room. Again, always wash your hands. It's one of the most effective things that we do to decrease infections in our patients. Don clean gloves and remove the old dressing using alcohol swab or adhesive remover pads as needed. Inspect your insertion site of catheter for signs of infection such as redness, bruising, swelling, discharge. Culture if necessary, and assess the security of the sutures because you need to have the catheter held in place as you apply the antisepsis. Remove your gloves after the dressing is off. Open your sterile gloves and create a sterile field using your sterile glove package. Then open your chlorhexidine gluconate, 2% with isopropyl alcohol, 70% swab, and drop it onto your sterile field. Open your transparent dressing and put that in your sterile field as well. Open your skin prep and place on the outer edge of the sterile field, and then put on your sterile gloves to begin. Cleansing the site. Cleanse the site with the chlorhexidine gluconate 2% with isopropyl alcohol 70% swab. Using friction or a scrubbing motion to apply, begin directly at the insertion site, and as you move the swab outward in a circular motion to cover all areas without retracing the area already cleansed. Some sites have identified that the package inserts requires a back and forth movement. There have never been a study that has been large enough or with a sample size large enough that we could say one way is better than the other. If your hospital epidemiology or infection control nurse prefers you to do it per the package insert, just apply that way. What is important is the friction motion and getting the chlorhexidine on the top and the back of all the skin cells that are in contact. Allow the chlorhexidine gluconate to dry by air only. Do not wave or allow fans to be used to dry. It takes about 2 minutes for it to dry completely, and please allow the 2 minutes so that the dressing will adhere appropriately. Now, preparing to place your dressing, you're going to designate one hand to be unsterile and pick up the skin prep packet. Remove the skin prep with the sterile hand. Apply the skin prep on the outer perimeter of the skin where the dressing edge will touch the patient. Do not put the skin prep over the catheter insertion site or immediate surrounding area. Allow to completely dry. Once the skin prep is completely dry, using your sterile hand, apply your transparent dressing per manufacturer's recommendation. And again, this means putting it down without allowing any air bubbles. You want it to go flat. You want to even it out. You want to make sure that it is firmly secured. You want to label your dressing with the date, your time, and your initials to identify when it was changed. If your protocol at your hospital is also to document in the chart, also document in the chart or on the flow sheet. And then finally, I'd like to talk about some other options that you have for dressing changes. At the time we put this together, there are a lot of alternative things on the market. There are bio patches, there are chlorhexidine impregnated catheters, there are chlorhexidine impregnated dressing changes. One of the most recent articles I read came out only a few days ago, March 25th, in JAMA, and it talks about reducing bloodstream infections from 2 per 1,000 to 0.6 per 1,000 using the biopatch. We do recommend the biopatch if you're having a difficult time keeping your infection control rates low. However, in looking at the JAMA study, it's very different than what we do. When they place the line, they do not use chlorhexidine. When they change their dressing, they change their dressings at day 1, day 4, and day 7, and they use isopropyl iodine. So instead of using chlorhexidine to clean, they're using the isopropyl iodine. I've also been to some sites where they use both chlorhexidine and a chlorhexidine patch, and really we've achieved results that are quite significant alone without the biopatch, but that is something that you should consider with your hospital epidemiology and infection control department if you are having elevated bloodstream infections. The same with impregnated patches and other antibiotic-coated catheters. They should be discussed thoroughly. If you're using the model for eliminating central line bloodstream infections, you should be able to achieve a significant reduction in just following the evidence used by the CDC as part of this collaborative. Thank you.